Okay, so on Friday, we kind of left off here talking about our cardiovascular center and the regulation of blood flow, which was kind of a continuation of what we talked about the previous class period. We talked about the cardiovascular center and its way of regulating heart rate and stroke volume, which therefore affects cardiac output. That's going to be something that will come into play again today because cardiac output is a way to regulate blood flow and blood pressure, and we're going to be talking a lot about regulating blood pressure today. We're going to be talking a lot about sympathetic and parasympathetic. We can't get away from those wonderful divisions of our nervous system. We're going to first get into today two reflexes that involve some of our input to the cardiovascular center, input from not joints, we're not going to be proprioceptors, but we're talking about the baroreceptors that monitor blood pressure, and then chemoreceptors that monitor various chemical concentrations in our blood. So let's talk about those two reflexes. These are quite a bit more complicated than those simple reflexes we learned about earlier in the semester. We talked about the stretch reflex when you tap on your tendon and your leg kicks out. That was an example of a somatic spinal reflex. Okay. Here we're talking about cranial reflexes because it involves your brain being the control center, not your spinal cord. And they're autonomic reflexes because it involves sympathetic, parasympathetic output. And both of these are regulated by way of negative feedback, which we know most of our control conditions are regulated that manner. Okay. We have talked about chemoreceptors in here, but we haven't really talked about baroreceptors. Baroreceptors are a type of receptor that you find in some of your blood vessels, kind of around your heart and up into your neck area. And their job is to monitor pressure changes. Okay? So these are pressure sensitive and monitoring stretch of the blood vessel wall. Okay? They send impulses to the cardiovascular center to regulate blood pressure when blood pressure goes up or down. And since this is negative feedback, if blood pressure goes down, we want it to go the opposite direction and bring it back up. So our first example or first demonstration is when blood pressure falls, baroreceptors are going to be stretched less, therefore having a slower rate of impulses sent to the cardiovascular center. This cardiovascular center decreases parasympathetic stimulation, increases sympathetic. We know sympathetic is going to do stuff to our heart, but it's also going to do stuff to blood vessels. Okay, it's going to increase heart rate and it's going to increase vasoconstriction of arterioles, both of which increase blood pressure. Okay. Whereas when BT decreases, those baroreceptors increases, baroreceptors are stretched more, faster rate of impulses are sent into the CV center. We respond with increasing parasympathetic and decreasing sympathetic. So we're doing the exact opposite as what we just did. And when the parasympathetic nervous system is activated and sympathetic is inactivated, our heart rate will decrease, ultimately causing cardiac output to decrease. Vasodilation will occur. That helps lower SVR. Remember, SVR is systemic vascular resistance. Both cardiac output both decrease cardiac output and SVR, lower blood pressure. Chemoreceptors, we have mentioned a little bit in this class, are going to monitor chemical concentrations. These ones are also located kind of around the heart. And they're going to monitor 3 chemical concentrations. The great thing is these 3 chemical concentrations are also monitored for regulating our breathing. And so we're going to see these towards the end of our next lecture, so we'll probably get into those on Friday when we get to the respiratory system. Okay. Those 3 chemical concentrations will be oxygen levels, specifically low oxygen levels in our blood, what we call hypoxia, high carbon dioxide levels, what we call hypercapnia, and then acidosis, which is a high hydrogen ion concentration. Okay. In response to those 3 things, and a lot of times they happen simultaneously, our cardiovascular center will increase sympathetic stimulation to our arterioles and veins, causing vasoconstriction and an increase in blood pressure. Here on the next page, we're demonstrating the baroreceptor reflex over here on the right with the negative feedback loop, and then over here on the left is actually what's occurring with the heart and the smooth muscle in our blood vessels. Okay. So here we're showing what happens when blood pressure decreases. Those receptors called baroreceptors are stretched less. Baroreceptors, like I said, are found in places like our heart area and our neck. Here we're showing the aortic arch, the carotid sinus, okay, which is the very beginning of the internal carotid artery. Okay. They are stretched less, therefore less signals go into our cardiovascular center. Okay. We respond by increasing the sympathetic and decreasing parasympathetic outflow. Increased sympathetic is going to increase heart rate. Going to make the SA node fire more often, like we learned about the other day. It's also going to make the heart contract harder. Both of those increase cardiac output. Cardiac output increases blood pressure. We also at the same time will be sending signals to our smooth muscle and the blood vessels, causing them to constrict. That increases systemic vascular resistance. Both increases in CO and SVR, as we just said, increase blood pressure, and therefore return to homeostasis, demonstrating, once again, negative feedback. Another way to regulate blood pressure is by way of those hormones, and some of these that we've seen before are listed here on this page. They can alter blood pressure a variety of ways. Altering cardiac output, so it involves that heart rate and stroke volume. Changing systemic vascular resistance, which is mainly going to be done by constriction and vasodilation of those blood vessels. Or just adjusting total blood volume. Now, when I say adjusting total blood volume, what do I mean? What's blood volume again? Amount. Okay. And think of it this way. What's in our blood that we can easily get rid of or retain? Therefore, adjusting blood volume. Water. Okay. And how do we regulate that? Well, we control how much water we pee out. Okay. And that's going to involve the last two especially. The first set of hormones are part of a system called the renin-angiotensin-aldosterone system or mechanism. I introduced this to you back when we talked about the endocrine system, and I mentioned that we wouldn't really get into it at this point. Well, now is one of those points. We're going to talk about this again when we get to the urinary system. Okay. But renin is a chemical released by our kidneys when blood volume falls or blood flow decreases to our kidneys. Okay, and that means blood pressure is going to be interpreted as low. Okay, if there's less blood volume, that means blood pressure is low. And this is a negative feedback mechanism, so we're going to do things that cause blood pressure to go up. We will use renin through a series of mechanisms. Okay. Angiotensin converting enzyme is in one of those mechanisms or chemicals that is activated. This acts on substrates to produce the active hormone angiotensin 2. Angiotensin 2 raises blood pressure by vasoconstriction and secretion of aldosterone. Anybody remember the nickname for aldosterone? Salt retaining hormone. Guess what we also retain if we retain salt? Water. And therefore, that's going to promote water resorption in our kidneys, raising blood volume, and therefore blood pressure. Yes, sir?
This happened during exercise.
Epi and norepi, we know those are activated for release when our sympathetic nervous system is activated. We've already talked about that today. Epi and norepi are going to cause the heart to contract harder and more often, therefore increasing cardiac output. That's going to increase blood pressure. They also vasoconstrict our arterioles and veins and our inactive organs. Places like our kidneys and our visceral organs, stomach, intestines, yada, 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 because we're not worried about delivering blood flow to those places when we're running from a bear or when we're just exercising. At the same time, we will vasodilate those blood vessels that feed our skeletal muscle and our heart muscle. But overall, the vasoconstriction that occurred with the inactive organs outweighs the vasodilation, and therefore blood pressure goes up when we release epi and norepi. Antidiuretic hormone, we learned, is going to also help us retain water. So that hormone that helps us pee less water out when we are dehydrated. That's one of the stimuli for secretion. Another one is decreased blood volume. Its other name was vasopressin because it increases vasoconstriction in our arterioles, therefore increasing blood pressure. And then atrial natriuretic peptide is the only one that's listed on this page that doesn't increase blood pressure. Okay, as it states on there, reduces blood volume, which a reduction in blood volume decreases blood pressure. This is actually released by our atria, so our heart, the upper part of our heart, that is, when there's too much blood flowing into it, basically. And so blood pressure would be high in that case, so we want to lower it. Table 21.2 is just a demonstration or kind of an easy way to organize what we were just talking about. Instead of breaking it down kind of hormone by hormone, they break it down by how it affects blood pressure, either cardiac output, systemic vascular resistance, or blood volume. And then it lists the hormones, and then the final column is what it does to blood pressure. There will be questions on the test related to what hormones do what to blood pressure and how they do it. So it might be a very easy table to study and helpful table. Over there on the right is a demonstration or kind of a chart to show how blood pressure will increase, several factors. We said blood volume increases. So will heart rate increases and stroke volume increases. We know we take heart rate times stroke volume, that gives you cardiac output. So you could just have one arrow with increases in cardiac output pointing to blood pressure increases. Blood viscosity, we learned, was the thickness of the blood. If that goes up, blood pressure goes up, which we said doesn't happen in a normal healthy situation. And then peripheral resistance increases will occur when we vasoconstrict our arterioles and that kind of stuff that we've talked about today and previously. A third mechanism for regulating blood flow and blood pressure is a term called autoregulation. Now, last week we got to learn the word autorhythmic with regards to the heart. Okay. This time we're talking autoregulation. What did the prefix auto mean? Anybody remember? Self is what auto means in this case. This is an ability of a tissue to automatically adjust its blood flow to match its own metabolic demands. So it's a way of self-regulating blood flow. It's a way that a tissue can affect the amount of blood that flows through its own capillary network. Okay, example is what happens when we exercise. We demand nutrients and the removal of wastes in high quantities, or as it states there, tenfold compared to rest. So our heart and skeletal muscle will auto-regulate to increase blood flow through those various capillaries. Also can control regional blood flow in the brain during different mental and physical activities, i.e. blood flow will increase to places like our motor areas of the brain when we're speaking. There are two different or general types of stimuli that can cause autoregulatory changes to occur. Physical changes like warming and cooling do the opposite of one another. Okay, we just used exercise as an example. What does exercise do to our body? Heats it up, so that's warming, okay? Especially the muscle itself. Well, warming will increase vasodilation. What's that going to do to blood flow? To the muscle, it's going to increase it. Okay. Cooling does the opposite, it vasoconstricts. Something that we're going to talk about when we get to the urinary system is a myogenic mechanism, which involves this myogenic response, which our smooth muscles will exhibit. Okay. It means that smooth muscle will contract more forcefully when it is stretched and relaxes when stretching lessens. For example, if blood flows through an arteriole, resulting in less stretch on the arterial wall, smooth muscle will relax, producing vasodilation to increase it. Okay, this is a great mechanism for regulating the production of urine. Okay, and blood pressure is going to be really, really tied in, as you can already imagine and already see, to regulating the amount of urine that we produce. So we'll be talking about these same things again in just a couple weeks. Vasodilating and vasoconstricting chemicals can affect blood vessel diameter. Okay. Things like white blood cells or cells like white blood cells, platelets, smooth muscle fibers, macrophages, and endothelial cells will release various chemicals. Chemicals that will vasodilate include potassium hydrogenide, lactic acid, adenosine, adenosine from ATP, nitric oxide, which we learned nitric oxide NO is a gas. It's a hormone, local hormone. Vasoconstricting hormones or chemicals include thromboxane A2, which we use that one, learned about that in the formation of not a platelet, but a vascular spasm. Part of that process when our blood is going to start spilling out, when our blood vessels are broken. Superoxide radicals, serotonin, and then endothelins.
We don't have to know those, specifically, do we? Those chemicals?
Wouldn't be a bad idea.
Okay.
Figures here on the next page showing on the left that stretch and myogenic mechanism that I was just talking about. Here we're seeing stretch is occurring, and that's from arterial pressure increases. That triggers the opening of mechanically gated ion channels that allow calcium in. A series of things happen, but what ultimately is the goal is smooth muscle contractions, which causes vasoconstriction in the arterial to counteract that increased arterial pressure. Okay. And that's that myogenic response I was just talking about. Here, we're just showing what chemicals can do to the blood vessel lumen. We've got vasodilating chemicals, vasoconstricting. You can definitely see a difference in the two figures. Here's something that I pulled from my exercise phys textbook. It's not something I'm worried about knowing for the test. Sometimes students are kind of interested in this, so I always like to throw it in there. It shows what various cardiovascular variables will do during exercise. We've got blood pressure, stroke volume, cardiac output, heart rate, something that we don't really get into in this class, but it's atrioventricular or arterial venous difference, and those are measured against or graphed against percent VO2 max. If you're not familiar with that, it's just a measure of exercise intensity, whereas 100% is the max that you can do. 0% would be you guys hanging out right now at rest. Okay, so heart rate standardly will go up, and it's a very linear relationship. Cardiac output's a very linear relationship, but it doesn't go completely linearly because it plateaus with regards, or because stroke volume plateaus. Remember, stroke volume is the amount of blood that's pumped each time the heart beats. Well, think about it. If your heart is going super fast, what's it not able to do? Fill up. Okay, so that will plateau off, and that means about 40% of our max is where we see cardiac output not increase quite as quickly as it was over here. The slope is less here. Blood pressure, systolic will rise, mean will rise. Mean doesn't follow the same linear rise. It's a lesser slope, and that's because diastolic actually will go down or stay the same, which is kind of cool. You don't need to know any of those. I just always like to kind of throw those in there and just show them off. All right, something that I'm sure most of you, if not everybody, has done in here is taken a pulse, whether it's on yourself or an individual other than yourself. A pulse is something that we usually use to determine your heart rate. It is a result of the alternating expansion and recoil of our left arteries, which are the arteries that receive blood from your ventricles. I'm taking mainly here the left ventricle. When it contracts, what we would call ventricular systole. Pulse is going to be strongest in the arteries closest to the heart, becomes weaker the farther it gets away. That makes sense. Normally, it is, like I said, same as their heart rate, about 70-80 beats per minute at rest, often used to measure heart rate. Bradycardia, we learned the other day, is slow heart rate or pulse rate occurring as a result of aerobic training, so being physically fit. Tachycardia would be the opposite, and this occurs for many different reasons. So you can get pulse from many different places. Probably the two primary places would be the common carotid in the neck, and then the radial artery in the wrist. Okay. You can also get them in other places in your face and head, down in your wrist, but on the other side of your wrist. The ulnar artery, even though it's not labeled, is a place where you can get it. Brachial artery, which we're going to talk about that, is where we take our blood pressure typically. Then there are several places down in your legs. You don't need to worry about any of this. One thing, though, I always like to emphasize when you're taking a pulse from somebody, what is something that you don't want to do? Usually found. Why is that? There's actually a small pulse in your thumb, and if you're testing to see if somebody's heart's beating, you might actually be interpreting that their heart is beating because you feel a pulse, but that's actually your own. So generally, your two fingers, index and middle, are used. Something that we talked about a lot the other day was blood pressure, and I've talked quite in depth about it today. Okay. Blood pressure, there are two of them typically generated when our left ventricle is in contraction or systole, and then in relaxation or diastole. Device used to measure this is called a sphygmomanometer, or sometimes just called a blood pressure cuff. It's a cuff that goes around the arm, is inflated, has a bulb to help inflate it, and then a valve to release the flow. And then you've got the little meter that helps you read off the two numbers. The two numbers come from the heart's contraction phase, what we call systolic blood pressure, and then the relaxation phase, what we call the diastolic numbers. Okay. When you take a blood pressure, you're also going to be looking, or you're going to be listening with a stethoscope for what we call Korotkoff cough sounds. These are noises that occur when blood first is able to run through the brachial artery, and then when it disappears is where you get the diastolic. The first sound that you hear is systolic, the last is the diastolic. Okay. So the larger number, systolic, over the smaller number, diastolic. Anybody know why we use the brachial artery?
Well, it's the main one that they use for blood pressure.
And why? It's an easy one to use first, but it's also right at the same level basically as your heart. So it gives a good idea of the pressure that your heart has to overcome to pump blood out, which we learned the other day is very important. Okay. If you took your blood pressure with your arm up above your head, what do you think is going to happen? Try again. And lower. The lower you get in your body, when you're standing, that is, or being vertically seated, the higher your blood pressure is. Why is that? Something we can't see, but we all know exists here on Earth, the force of gravity. Something that also affects like water flow. If you live on a hill, guess what's going to happen to your water flow in your house? It's going to be weaker than if you live at the bottom of the hill. All right, last thing here, talking about some blood vessel disorders. Some of these we've talked about before. Arteriosclerosis, group of diseases characterized by a thickening of the walls of arteries and the loss of elasticity of those arteries so they don't stretch and recoil as well. Atherosclerosis, we've mentioned before, is where you get the plaques in those larger and medium-sized arteries. If you get those plaques within your coronary arteries, you are going to have coronary artery disease or heart disease, sometimes it's called. This is very dangerous because it's a precursor to heart attack or myocardial infarction. And then hypertension, which is the fancy way to describe high blood pressure, abnormally high pressure in our arteries. Okay. And there are three major categories to which you can be classified: normal, pre, and hypertensive. Okay, based on your numbers, you can see I bolded and underlined the words and or. Okay. For normal, you have to have both less than 120 and 80. Pre-hypertensive between 120 and 139, or 181 to 89. And then hypertensive, okay, put a equal to sign, so greater than or equal to 140 and 90 over here. Okay, so that symbol, that's Greater than or equal to. Remember that from math class. There will be at least one question I'll throw in there on your test. Blood pressure of, let's use example 132 over 68. Okay, what would that person be classified as having? Pre. Okay. 132 falls here. 68 falls here, but just having one of those numbers in the pre-hypertensive area gets you classified in that area. Now, one thing that's never going to happen is going to the doctor and having a blood pressure high one day and getting automatically classified. And a lot of different things can affect your blood pressure and just your mood on that day. Okay, somebody just broke up with you before you went to the doctor. Guess what's going to be going on with your heart, your blood pressure, all that wonderful stuff. Chewing gum, crossing your legs. Anybody ever heard of white coat syndrome before? Okay, fear of doctors. Guess what? It's going to happen to your blood pressure. I went into the dentist. They take my blood pressure at the dentist now. It was absolutely astronomical one day when I went in there. I wonder why. Wasn't excited about going to the dentist, but